So what are the key roles? And the roles that we work with are firstly a responsible medical officer who takes, in most effective services, the lead. A prescriber, a key worker, somebody who takes on responsibility for social forensic problems, a therapist, somebody who is responsible for crises, and a system that backs them up, and also inpatient access and ways of ensuring that's inevitably available. So, what are the things that UK experts in relation to setting up specialist personality disorder services all agree about? They agree about actually a surprising number of things. They agree that it is better to have, as evidently you are doing, dedicated personality disorder teams. It is better to have treatment plans that are long-term. It is better to have organized, structured crisis intervention. It is better to have boundaries and expectations agreed with patients from the very beginning. It's better to have responsibility shared within the team. It's better to have team members who all accept that they are working in a high-risk environment. And the way I think about it is, when you're recruiting for people to work in a submarine, that's very different from recruiting people who want to work on the cross-channel ferry. There are risks associated with working in a submarine. Accidents can happen in the cross-channel ferry, but you feel much, much more anxious when you are a couple of miles under the surface of the sea. And this is part of what we accept as a working environment. This makes the personal qualities of the staff we recruit enormously important, and I'll come back to that. That's generally agreed. It's also generally agreed that it's important to have reflective practice in teams. There is an opportunity to look at what we are doing in a systematic and boundaried and contained way, regardless of the approach that we take. But not all in the UK agree on some of the details. There are major areas of disagreement, and I wonder whether there are any of these correspond to disagreements that apply here. One area of disagreement is to what degree should there be separate services from general mental health to personal. Everybody agrees there should be specialist teams, but should these teams be based within community mental health teams or not? Okay. A second issue of disagreement is whether referrals should be specialist referrals, tertiary referrals, secondary referrals, or primary self-referrals. There is controversy in relation to this. There is major disagreement to what extent research is an adequate guide to service development. And as someone who's fairly, in the last 35 years, I've done nothing much except research, I'll have to say that, and I'll come back to that the research in many instances is not a good guide to service development at the moment. There's no agreement whether group work is equivalent to, superior to, inferior to, necessary for individual work with these patients. There's no agreement whether 24-hour access is required or not. There's no agreement whether assessments should be done in the home or in a clinic setting. For example, users of services believe strongly that assessments should be done in the home. There are some service managers and clinicians who beg to disagree on this. And as someone who's kind of worked with a home treatment team for a while, often these patients do not let the home treatment team in. So it's not necessarily a very efficient use of resources. But, there are different views. So, let me now turn to a new intellectual framework for psychotherapy. Is the treatment model that we use for personality disorders important or not? This is one of the controversial issues. And we've got good evidence, fortunately, that a range of structured treatment programs for borderline personality disorder, for example, have been shown to be effective randomized controlled trials. So DBT, SFT, schema-focused therapy, CBT, transference-focused psychotherapy, MBT, all these have been shown to be effective against treatment as usual. And in fact, actually, it's very clear that as long as the acronym has 3 letters, it's going to be effective. What I would not advise on the basis of the evidence is to have a treatment that's a 4-letter acronym. It's obviously not necessarily helpful for this group of patients. But these are again effective against treatment as usual or inappropriate comparisons. But they're all fairly specialist interventions requiring extensive training and continued supervision. Mary Zannarini has a recent paper in Acta Psychiatrica that argues strongly that actually it's not so much a treatment model that should determine where we send patients with BPD, but much more the cost of that service. What we need more of are cheap services rather than this is an American perspective, but it's clearly there is a point here. Now, the current evidence base favors DBT. CBT is not very well supported, and schema focus, transference focus, or mentalization-based therapy are supported by fewer trials. We have a more recent trial that I'll be able to talk about in the workshops this afternoon. But that's not really where I want to go. I want to go to the recommendations that the National Institute of Clinical Excellence made in relation to cluster B personality disorders, in relation particularly to borderline personality disorder, as to where research should go. What we didn't know, what is it that we don't know? And it seems that we don't know. Firstly, is if DBT or MBT, when it's delivered in a well-structured, high-quality community care setting, is superior to general mental health services without psychological interventions when they are similarly well organized and run by expert groups. Now there's a recent trial on DBT, for example, from Canada, where a well organized and well-managed